Today I'm presenting on the PEDS CCM case. As always, we'll start with a case. So we have a 12-year-old male, no history, basically presented for abdominal pain and vomiting for about 3 to 4 days. Started with a fever, had some vomiting, intermittent episodes, non-bilious, non-bloody, nothing in his poop as well. General mild pain, dull, recent travel to Grenada, no antibiotic use, and the rest of the history was pretty much normal. On exam, the things of note, pain scale is about 5 to 10. Generally, he looked mildly dehydrated. He was definitely acting age appropriately, he was smiling, making eye contact. There was moderate amount of scleral icterus, dry mucous membranes. His belly exam is diffusely tender, and the rest of it's pretty normal. Neuro exam was negative for anything as well. So the initial assessment gives my IV fluids, get some labs, noted for the abdominal tenderness and jaundice on eye exam. Blood test, give you guys a second to take a look at this. If anybody wants to shout out any issues, any abnormal values, feel free to do so.
Is a leukocytosis? Oh, never mind.
The ammonia is super high.
Correct. Yeah, just in broad stroke, I mean, LFTs are just way off. But the things to note too, yeah, coags are off, INR is 2.6. He's a little hypoglycemic. LFTs are up, including ammonia that somebody mentioned. And the direct billy is 15. These are additional labs that were taken. The ceruloplasmin, if somebody's thinking of Wilson's disease, it's usually low in Wilson's disease. It's an acute phase reactant as well, so possibly high in that case. And then the UA, you can see that he's essentially spilling out bilirubin and urobilinogen.
Kenny, do you mind just going back to the previous slide?
Sure.
Great. I just remember talking in my group. I just had briefly said like LFTs are just a sign of liver inflammation. They're not actually function tests. So if you're looking at function, you're looking at albumin, you're looking at glucose, and you're also looking at your prothrombin time. Yeah. And I just think it's interesting, you know, like you have this kid who has like affected INR, which means the prothrombin time is affected, a little hypoglycemic, not super, 63 isn't terrible, but still lower than you expect. And then especially in someone who has this amount of inflammation, you would expect the platelets to be higher too. And they're relatively normal for someone who's in a higher inflammatory state. So I find that really interesting.
I think albumin usually takes a little while to cycle through. So I think it's 3 to 4 weeks. And I'm not really sure about the coag and all your factors, but it might just show that it's a more acute process / subacute rather than a chronic issue. Imaging was obtained. We got a bedside ultrasound. It showed some gallbladder wall thickening. The official just showed a coarsened parenchyma. This is just a Google image of something that showed coarsened hepatic parenchyma. Again, the gallbladder wall thickening and nothing else. So the treatment here, we got some Zofran, dose of vitamin K and some fluids. And then the assessment was that this could be a viral etiology versus toxic ingestion. Essentially, the family really denied taking any Tylenol, so acetaminophen toxicity was ruled out by history, and the diagnosis was acute liver failure hepatitis. I'm just going to spill the beans here, and the outcome was that transplant team at Columbia was called. Their hepatologist accepted the patient, and he was transferred to the Columbia PICU. He underwent a liver transplant within a week, which was partially donated by his mother, which is really sweet. So we're going to talk about pediatric acute liver failure. I watched a bunch of videos. I don't think anybody referred to it as PALF. I might do that during this presentation just to start a new trend. So background, in terms of the definition, it's a clinical syndrome in the context of no pre-existing liver disease or cirrhosis. The criteria is that you're having hepatic failure within 8 weeks of onset of clinical liver disease. It just speaks to how fast this progresses. And also, you may not actually know the exact onset of clinical liver disease or jaundice unless you really say had a toxic ingestion, you know which day you took it. Other criteria is that you have some biochemical evidence of acute liver injury, your coagulopathy is not corrected by vitamin K, and encephalopathy, although this is not a requirement, which makes it different from adult liver failure where it is a requirement. It's not a requirement in large part because it's pretty hard to assess age-appropriate mental status in kids, especially if they're younger and infants. It's hard to find out numbers and incidence of pediatric acute liver failure. There's 17 cases of acute liver failure per 100,000 people per year in the US, and this is across all age ranges. Unknown frequency of children, it does account for 10 to 15% of US pediatric liver transplants. And in 2019, there were only 551. In terms of etiology, it's really separated between developed countries or the global north and developing countries or global south. For developed countries, overall, it's about 40 to 50% that's indeterminate etiology, and it goes as high as 60% for pre-adolescents. For infants, it's mainly focused on metabolic and infectious etiologies. Galactosemia is the most common one. It's only 7% though, and mitochondrial disease. A lot of these diseases are part of the newborn screening. Herpes simplex is the most common infectious etiology. And for adolescents, that's where you get into drug-induced and autoimmune diseases being more common. 21% of adolescent acute liver failure are due to Tylenol toxicity, and that accounts for 75% of all drug-induced liver failure. Autoimmune and Wilson's disease follow that. And you see for developing countries, the main cause is hepatitis A, B, and E. Just a table for just to show you the etiology across North America and Europe. Again, it's 45% that are indeterminate. And I pulled this from a slide from a pediatric acute liver failure lecture from India, but you can see the difference. Hepatitis accounts for about 75% of all cases. So a big difference between us and someplace else. And just a table breakdown of the etiologies by sort of age ranges, age categories. And these are medications and toxins that are associated with acute liver failure. You can see a lot of antibiotics around here. You have seizure medications, toxins. We learned about mushrooms in med school. And then as you get a little older, maybe adolescents, you have some recreational drugs, ecstasy and cocaine. So in terms of your workup, you want to get a good history, just talk about or find out about the symptoms, when the jaundice started, some travel history, hepatitis exposure. You also want to get a pregnancy history and assess for risk of congenital infections, as well as medications they have access to. And then, of course, your past medical, metabolic diseases, autoimmune diseases, and newborn screen results. In terms of presentation, you have the belly pain, fever, malaise, jaundice, sclericterus, but just want to focus on encephalopathy, which you find in actually more than half of patients on admission. We typically on the adult side use this West Haven criteria. You go from grade 1 to 4, 4 being coma and 1 just having some mild impairments. But of course, if you have, say, an infant or a younger child, it's hard to assess all these things. So there's a criteria for pediatric encephalopathy for children that are less than 3 years. But you note that grade 1 and 2 are essentially grouped together and indiscernible. And then you can see that neurologic signs are really not useful in this unless you get into late stages. Ascites count for 22, or ascites is in 22% of the pediatric acute liver failure, and then you have seizures as well in 7%, 7 to 11%. Just in terms of exam findings, you guys might recognize this from first aid. This is the guy that they showed for cirrhosis and signs and symptoms of it. I just updated a little bit and make him look younger. But you have your jaundice, you have your TKI, you have your ascites, signs of thrombocytopenia, hepatic encephalopathy. In terms of your lab work, these are generally the basic labs you want to get. Your CBCs, your electrolytes, your LFTs. I think we just mentioned this before, but there's a difference between biochemical tests, which point to liver injury, and that includes your AST, ALT, and ALK Phos. And then you have your functional tests, which point to the liver function, and they're usually the products that are synthesized by the liver, and these include albumin and coags. You also want to get ammonia level to assess for your encephalopathy, blood gas, just get a lactate in your pH, and then acetaminophen levels. It's pretty low-hanging fruit. It's a pretty common cause of liver failure, and it's treatable, so you want to get this as well. You can see on this graph that these are general ranges of transaminases for different liver pathologies, but more acute ones you can see are the higher end, from the upper hundreds to thousands. This chart is from up to date on what other tests to get. A lot of these you might not necessarily send from the ED. So our job is basically to treat any acute issues, stabilize, and then dispose. So a lot of these won't even come back for several days. But if you're working in a facility where it's more vertically integrated, where you're just dispoing to your own ICU or transplant center, maybe you can start this. But there is a differentiation between tests that you order for neonates and infants versus those that are a little older. I mentioned the herpes. You get a hepatitis panel based on the history. Again, get your acetaminophen levels. That's better. You can read the rest of these. And again, additional workup, blood cultures, but then go into the less common ones like Wilson's disease and other metabolic diseases.
So I wanted to just quickly add, good job with those slides. Wilson's can be very rapidly progressive. We had a patient in residency who went in less than 6 months to fulminant hepatic failure from Wilson's. So it can be very, very quick.
And for that, you'll probably have more history on that in terms of some neuro issues and psych issues. And if you want to test your eye exam as well, you can do the Kaiser-Fleischer.
So in the ED, you will probably not, like, you can look for the Kaiser-Fleischer, but you probably won't find them. Yeah. This kid was totally neurologically normal, and they only figured out it was Wilson's when they did his ceruloplasmin and then biopsied. But he went from totally okay to complete liver failure with coagulopathy in a period of months.
Thanks. In terms of imaging, we can perform our own POCUS. You're not really going to find too much in terms of etiology, but it's just a general sort of picture of the liver to see if it's coarsened or if there's any abnormalities. You can consider getting an official one as well, where you can get flow and assess for any vascular pathology. Typically, a CT or MRI abdomen is less indicated unless you have a reason for it. If you're looking for malignancies or METs, or more on the vascular issues like Budd-Chiari. You can consider CT MRI of the head as well to assess for altermental status. And we'll talk about that later. And then in terms of liver biopsy, obviously we don't do this in the ED, but for a consideration, it's typically not indicated, generally because it's low yield, plus patients do have coagulopathy, so you might have increased risk of bleeding, but they usually go through a transjugular approach, which decreases the risk of bleeding. This sono is just an example of coarsened parenchyma here. You can see that it's not homogeneous as opposed to the one on the left. So in terms of management, so why CCM? I mean, it's a GI/liver issue, but it has a lot of complications. I'm sure we all know that the liver provides a lot of different, or it does a lot of tasks that influence basically every system in the body. So because of that, it's important to think through the systems and then involve your specialists as well, hepatologists, ICU, neurologists, nephrologists if needed. And then come up with a dispo plan, either ICU versus a liver transplant center. Again, there's a lot of clinical manifestations of acute liver failure. I think we'll just focus on the main ones today. So in terms of neuro, just a little pathophys. So the liver helps detoxify ammonia. Basically, it goes through, it converts it into urea through the urea cycle, and then it gets excreted by the kidneys. But it's not the only organ that processes and detoxifies ammonia. It's actually done in a lot of other organs and peripheral tissue, and it gets converted into glutamine. So if your liver is not doing too well, you're going to have a buildup of ammonia, and then a buildup of ammonia spreading throughout the entire body and conversion into glutamine. The brain astrocytes actually convert this as well. So you'll have excess glutamine within the astrocytes intracellularly. And it's thought that there's an osmotic effect where because of the increased glutamine, you're going to have draw of fluid and water into these cells, causing cerebral edema, increased intracranial hypertension, leading to hepatic encephalopathy. So this is one of the more feared complications of acute liver failure. So what you want to do is do frequent assessments and serial exams. You want to also address any factors that might be causing change in mental status. Includes hypoglycemia, infections, shock, fevers, electrolyte abnormalities. Elevate the head to improve CSF drainage. And you should consider intubation, especially when they're grade 3 or 4 in terms of encephalopathy. If that's the case and your ammonia level comes back high, you can consider ammonia lowering medications, including lactulose, rifaximin, and neomycin. There's limited data on how fast or if they're even effective in acute liver failure, but something just to start. And then if you really need to, you can consider CRRT, especially in the advanced stages. And it's definitely been shown to reduce ammonia levels by almost 40% in the first few days. And it actually improves 21-day transplant-free survival. So with encephalopathy, you want to make sure you assess for cerebral edema and increase intracranial pressure. So you can do it by clinical suspicion. The patient's altered, they have severe headache, they're vomiting, but it's pretty non-specific. We've also been taught the Cushing's triad, where you have hypertension, bradycardia, and then this irregular breathing. But again, this isn't always present with having all three, and irregular breathing is pretty late stage of having increased intracranial pressure. So you can go to your imaging, CT, MRI. These are pretty good options. They're non-invasive, and it might be difficult to get if the patient's crashing or they're critically ill. But typically you look for signs of edema if you have obscuring of the sulci and the cisterns. Another option, which is considered a gold standard, is actually to do direct intracranial pressure monitoring. And this includes using an intracranial bolt that's seen here, or doing EVDs. Obviously, you're going to have to involve neurosurgery to get to place these. There is a risk of intracranial hemorrhage. Again, there's coagulopathy with liver failure. Likely this won't be done, and there's other non-invasive options for this. We're pretty familiar with ultrasound, so there's a couple options that we can do to assess for this. One is the optic nerve sheath diameter. There's a paper out in India that looked at the pediatric population, those with hepatic encephalopathy and those without, and they determined that there's a cutoff between at 4.6 millimeters for your optic nerve sheath diameter. To measure this, you go 3 millimeters below the globe, and then you measure across from the sheath. You do 3 measurements and you do the average of all 3. It hasn't been really validated yet. Even in adults, a normal number is usually below 5, but between 5 and 6 millimeters, it's somewhat equivocal. And you really suspect it if it's greater than 6. But for children, it hasn't really been validated what the normal is. Supposedly below 4 for infants, and then below 4.5 for children. Also, for that study, they only studied 7 to 15-year-olds. They couldn't get any younger than that. So this is just a general cutoff to take lightly. The sensitivity was actually not that great either. It's 82%. So another option is to do an optic disc elevation. This was studied in the States, and they had a cutoff of 0.66. It had a higher sensitivity, 96%. And instead of hepatic encephalopathy, they compared it with, try to compare it with more objective findings of increased ICP, including LPs, ICP monitoring, and imaging. So
yeah, just be very careful with these measurements, because like you said, a lot of this data is even extrapolated from adults. So with kids, there's no exact measurement. You know, I've had kids with 5, 6, 7 millimeters, and they had no ICP, normal scans. I would pay more attention to the cupping of the optic disc as opposed to the measurement itself.
Good point. I would also say for these intracranial bolts, there's no normal value that's been studied in kids. Obviously, they wouldn't just put bolts in children just to measure the normal pressure. They only measure pressures in essentially sick kids. So the cutoff for treatment is usually 20 millimeters of mercury, but there's no consensus of how far this is away from normal. Is it a large difference for infants versus somebody that's 16, 17-year-old? Yeah, no studies on that. So in terms of management, I think we're pretty well aware of this formula. Cerebral perfusion pressure equals MAP minus the intracranial cerebral pressure. So the thought process is to decrease your intracranial pressure so that you have increased cerebral perfusion. Just keep in mind that you also want to maintain a map so that the entire formula on the right side doesn't drop to decrease your cerebral perfusion. So your options to decrease the pressure, you have osmotic therapy. I said savory versus sweet, where you can have hypertonic saline versus mannitol. Hypertonic saline is generally the preferred method just because it's been studied for pediatric intracranial hypertension in traumatic brain injury. So they kind of extrapolated that it might be more effective. It could be as effective here. Again, that hasn't been really well studied, but that's generally the standard. Your target for saline or sodium, serum sodium is about 145 to 155. You want to be wary of how hypertonic of a solution you want to use. Generally, you can use 2% via peripheral IVs, maybe 3% if you have a large bore one, but anything higher than that requires a central line. You'll have to also do frequent sodium checks, make sure that the kidney function is okay. It does sometimes cause hyperchloremic acidosis, metabolic acidosis, so just be aware of that. If you are using mannitol, again, this is more of hypertonic saline fails. It hasn't really been studied in pediatric acute liver failure, though. Hyperventilation is an option. A lot of papers and guidelines are saying this is also a last resort, where it hasn't been really proven to show any benefit in mortality. But for this, if they are vented, you're looking at a goal of maybe about arterial CO2 of 30 to 35. Some other papers were saying 35 to 40, but this is transient though. You want to keep the patient hyperventilated for a day or two. You want to do it for maybe half an hour to just 2 hours, just to bring the pressure down a little bit if it actually does bring it down. The goal is to decrease your cerebral blood flow, and hopefully bring down your ICP. But keep in mind, if you're decreasing your blood flow, you could also be decreasing your MAP as well. Make sure you have your end tidal on and check serial ABGs. And then therapeutic hypothermia is a more novel approach. The thought process is that you're decreasing anti-inflammatory effects. You're also decreasing metabolic demand. And some places have used this as a bridging technique to liver transplant, but it hasn't really been shown to be really having a change in mortality. So I would likely hold off on using this. In terms of seizures, they're present in about 11 to 16% of patients. You don't want to have seizures, obviously, increases metabolic demand. It's associated with increased mortality. The first line agent is phenytoin. And the reason for this is that it's just been used in adults as a first line. So they're extrapolating it for peds population. The second line tends to be Keppra, which I would assume that we're all more familiar with and comfortable with, but definitely preferred over benzos. A lot of the benzos are hepatically metabolized. You don't want that stuff lingering around for a while. In terms of respiratory, up to 40% of patients require vent support. If you do it, you want a lung protective settings. You want low tidal volume, about 6 to 8 cc's per kg, and then moderately elevated PEEP, maybe 5 to 8. In terms of your sedatives, you want to avoid, again, your benzos, but also your Precedex. They're pretty extensively metabolized by the liver, and they'll have decreased clearance. The other agents that we typically use, propofol, etomidate, and ketamine, are metabolized by the liver, but there's an anesthesiology article that showed that even in pretty advanced liver disease, they aren't really, the clearance of these medications aren't decreased significantly. So you can consider using propofol. It has been shown to reduce intracranial pressure. So that's your go-to agent, although it does potentially decrease your MAP. So just be careful. So I'd use them in somebody that's hypertensive or pretty stably normotensive. And then your second line is etomidate. For your neuromuscular blockades, you want to avoid rocuronium and vecuronium for the same reason that they're metabolized by the liver considerably. Succinylcholine, there's a theoretical decrease in clearance, but your go-tos are atracurium and Nimbex. Cardiovascular wise, generally, that if somebody's not feeling too well, they're going to be volume depleted. They're not taking much through PO. So this could be the main reason why they're hypotensive. There's also increased amount of cytokine release, so that could add to decreased vascular resistance. You could also have hepatorenal/hepatoadrenal syndrome. The pathophys is here to the right if you want to take a look through it. But essentially, the portal hypertension is going to cause vasodilation in your splanchnic circulation and peripherally. And then you're going to have your RAS system that's going to respond to it by clamping down on your renal vasculature and decreasing blood flow to your kidneys and decreasing your GFR. So again, you can try fluid challenge with this, maybe 10 to 20 cc's per kg, see if that works. Put them on drip or fluids if needed, but slowly. You want to be really careful to balance out the amount of fluids you give, because if they do have cerebral edema, you don't want to exacerbate that. If their pressures still aren't holding, preferred pressor is as Levophed. And even with that, if it's not working, you can try systemic steroid for this hepatoadrenal insufficiency. You can try hydrocortisone 2 to 3 mg per kg. Renal wise, AKIs associate mortality, and it's actually found in about half the patients that come in with pediatric acute liver failure. Again, you want to try a fluid challenge. This could be a hypovolemia picture. You can also get your FENA, but keep in mind that perfusion is also part of the pre-renal picture. So you're going to have a FeNO less than 1% and low sodium in your urine. So it's not going to be too helpful in terms of differentiating whether this is hypovolemia versus a perfusion picture from hepatorenal syndrome. And then if needed, you can consider CRRT. This is the preferred method of kidney replacement, mainly because it doesn't draw out a significant amount of fluid, causing a lot of fluid changes, and it doesn't really impact your blood pressure as much. There's one study that showed about 10 to 20% of patients required some kind of hemofiltration support. In terms of your infections, the ones not to be missed, your herpes, your varicella zoster, you can consider CMV and EBV in this as well. The main thing for these is that the mortality is super high. It's about 80%. And sometimes you might not catch it because even disseminated HSV, with HSV hepatitis, you may not have lesions, the typical lesions. About 40% don't have lesions. So this your history is pretty important here in terms of finding out the pregnancy course and any complications or whether the mother had been tested prior. You can send for your serum HSV studies. Unfortunately, these are send outs at county. If the history fits, though, just start empiric treatment of acyclovir. For varicella zoster, though, typically the child will have rashes, so it's a little more evident here. And otherwise, you may have sequelae infections. You have decreased, or patients that are in acute liver failure are often more immunocompromised. So if you're suspecting sepsis or some kind of systemic infections, get your cultures, start your broad spectrum antibiotics. Ascites is common. in liver failure. So considering getting studies for SPP. In terms of hematology, as mentioned, part of the criteria for this is to have coagulopathy that's not corrected by vitamin K. So you can try one-time dose of vitamin K to see if your INR improves. If not, then likely it's not vitamin K deficiency. It's something that's liver induced. But bleeding is typically not a main problem with these patients. Clinically significant bleeding is less than 5% of patients, and then intracranial bleeding is less than 1%. Transfusions are usually not recommended unless there's active hemorrhage or you're going for a high-risk procedure like a biopsy or going for intracranial pressure monitoring procedure. In that case, you do want to correct it. Consider giving FFP versus PCC. The benefit of PCC is that you have lower volume, maybe about 100, 120 cc's versus FFP, it's 10 to 15 cc's per kg. In terms of your platelets, the recommendation is that you don't transfuse until you're at 10K for asymptomatic and 50K for these procedures. FENGI, hypoglycemia. I think we talked about this during the CBL, but you can consider, I mean, Adam mentioned the 50 rule, but for neonates, you can give them 10 D10 water pushes, 5 cc's per kg. So 10 times 5 is 50. For peds population that's a little older to 8 years old, D25W at 2 cc's per kg, and then greater than 8 years old, you can do your D50s. And then if needed, you can start your drips. Keep in mind that D10 water can go through a peripheral line, but anything more concentrated than that, you'll need a central line. If you're pushing the D50, just do it slow to decrease risk of irritation and extravasation. We mentioned ascites. If not suspecting SPP, don't tap it. You may cause some fluid shifts that's unwanted, especially in the case of cerebral edema and whatnot, and hemodynamic instabilities. And then NAC. So we're all familiar with NAC, especially for acetaminophen-induced acute liver failure. The dosing is about the concentration. Sorry, the dosing is the same for per kg as is for adults. The same for peds. You just have to change the diluent around. There's protocols on that you can look up. When I was in the ICU, they started using NAC for non-Tylenol induced acute liver failure. Some studies have shown some benefits, but overall it hasn't really been shown to improve mortality for all patients, but just the ones that have fairly low-grade hepatic encephalopathy and sort of early liver disease. So it's not indicated for all adult patients. For pediatrics, they have had a few small studies, but it really hasn't improved anything. It hasn't improved mortality, ICU length of stay, or the highest grade of hepatic encephalopathy. So unless you're suspecting Tylenol toxicity, don't use it. It does have side effects of anaphylactoid and anaphylaxis reactions. So the last step of this is essentially a liver transplant. For somebody that's super sick, obviously, just in a general sense, in a clinical sense, you want to transport them as soon as possible. As I mentioned, about 10 to 15% of all pediatric liver transplants are because of acute liver failure. The main thing you want to do before that is just look for reversible etiologies, so that if you do get a transplant, you're essentially saying that your liver can't reverse itself. It can't spontaneously improve. But the problem is if you do transplant, you never know whether the liver could have regained its function and gone back to normal. So you're subjecting a patient to a transplant that might not need to be transplanted. So look for your reversible causes and address them first. There are a few contraindications like uncontrolled sepsis, pretty severe cerebral edema that's likely unreversible or causing irreversible damage, and then multi-system mitochondrial disease, which has a pretty overall poor prognosis. I just want you guys to be familiar with these scoring systems, although they probably won't play a huge role in the ED. The King's College Hospital criteria, we use this on the adult side too, in that if you hit one of these criteria, you should be transported to a transplant center. There was a study recently done in 2013 that tried to use the criteria for non-Tylenol-induced acute liver failure to try to see if it was a good predictor of death at 21 days. It's not. Sensitivity was 61%, specificity of 70%. That means that 61% of the patients that died met the criteria, which leaves a large percent of the patient that died out of hitting this criteria. What it did show was a negative predictive value of 88%. So essentially that those that didn't meet the criteria, 88% of those survived at 21 days. So it's a decent predictor of survival or spontaneous survival without a liver transplant. So you can take that into consideration when you talk to the transplant teams and transfer centers. Another score is the PELD score, which is kind of the analogous scoring system for MELD score. Essentially, this is what score is used for putting a patient on the transplant list. So the higher the score, the higher you are on the list. Obviously, we're not really going to be using this too much. If they're in liver failure, they might need an emergent transplant. Just of note, though, if they do need an emergent transplant, they're basically fast-tracked to the front of the list if they meet criteria for fulminant liver failure. So these are the transplant centers in New York City. Our patient was sent to Columbia, but they do have them at Montefiore and Mount Sinai as well. In terms of prognosis, just get Tylenol-induced liver failure out of the way first. It's pretty good prognosis, 94%, 21-day survival. For the rest of the population, there's a study group that had about 700 plus participants. So about 55% of them survived, 11% mortality overall, and 34% were transplanted. For that study group, they didn't actually mention whether those transplant patients survived or not, but there's a database that where all pediatric transplant patients are registered to, but there's under this database, there's a 74% one-year survival for patients that received a liver transplant for pediatric acute liver failure. And this is in comparison to 88% one-year survival for those that were transplanted for other reasons, like chronic liver disease. So you can see that the one-year survival is actually a little worse off. In terms of those who passed, the main reasons why they died were multi-organ failure, cerebral edema, herniation, and sepsis. And you can see survival is actually correlated with hepatic encephalopathy. So the worse, the higher grade you have, or if you have any encephalopathy, the worse you are. There's very little data or mention about the long-term effects of hepatic encephalopathy. The few things they mentioned was that they might have worse executive function, decreased attention span, and just overall worsened quality of life. Those who had Tylenol induced liver failure, they had higher instances of psychiatric and substance use disorders. So in terms of summary, just be able to recognize pediatric acute liver failure. I mean, those labs that we saw in the beginning, obviously that should strike some fear in everyone's hearts. Try to treat the reversible causes, including your NACs, your antivirals, recognize complications and act upon them. So recognize cerebral edema, use any means of identifying it, your clinical exam, imaging, and your ultrasounds to just kind of build this picture up. Look out for a hepatic encephalopathy. You can treat for that as well with your lactulose and your Faxamine, airway protection, volume control, volume management, and BP control with your pressors if needed after a fluid challenge, and then hypoglycemia. And ultimately, you want to transfer them to a transplant center. Questions?